Okay. Slow down yet a little, Lyndon? Are we still?
Yeah, I think so.
Yeah, we're good. Okay. Well, I think we'll make a start then. It's at 11 o'clock and we've started recording, just to make everyone aware that we're going to record the sessions and try and make sure that they're available for everybody. And there'll be people who've joined us today and others who couldn't make it. We've got some wonderful presenters today to come and talk to you about their experiences of co-production, and we'll be talking with Nikki Scott and with Michael Farrington and Lee O'Neill about their work. We've got a short introduction, but some housekeeping first. We are recording this session. We will have time for questions after each presenter, so if you would like to put them in the chat or you would like to ask them in person, please just raise your hand or put them in the chat, and then we will be able to come around and have that discussion so that you can get a little bit more information if you want, or you've got sort of follow-up questions to ask. We're going to just start off with a little bit of an introduction about why we're here, and then we'll move straight into talking with our presenters and seeing the work that they've been doing. Okay. So as I said, we have a duty to involve, and our co-production is part of that. We have a legal duty to involve in the residents of Bedfordshire, Luton and Milton Keynes in the work and the decisions that we make about health and social care. If we look at our own documentation about how we're planning to work together, residents shaping the strategy and service delivery are right at the heart of how we work in the new health and care system. We have a duty to support, and we have a duty to support our staff and a commitment to support staff and partners and service users to collaborate together. And with our engagement early on when we started on this project, we've highlighted that staff have asked for initial training, skills development and ongoing support. And that's what these webinars are part of. So with the initial training, we're going to be providing training with the Consultation Institute, which started in January, which provides an overview of the key legal and statutory principles, an introduction into the principles of co-production, what it is, what it isn't, and you'll be able to gain practical tools, methods and support to support your co-production work. They're 2 3-hour sessions, including a mid-session break, and they're interactive online sessions. But you need to attend both the morning and the afternoon sessions to complete the course. They're running most Tuesdays and Thursdays from January through till May, so you'll be able to book them. And you can book them by clicking on any of our QR codes here. And we will put these up and we will put the link in the chat as well for you to do that. If you have joined already and done your training already, you'll be able to maybe apply some of the things you've learnt to some of the experiences that our presenters have. If you're yet to do that, it will give you a really good insight into the practical working of co-production and what it looks like, and you'll be able to apply that to your training. So it will work both ways around for folk. So without any further ado, I'm actually going to try and work. There we go. Have I stopped sharing is my next question. Oh, thank goodness. Without any further ado, we're going to introduce our first presenter, and I'd like to introduce you to Michael Farrington and Lee O'Neill.
Great, thanks ever so much for inviting us today. So apologies, I can't turn my camera on. So I've got a real IT problem, even though I'm in the office. So apologies that you can't see me today. So so hopefully I'm Michael Farrington, working across Bedfordshire, Luton and Milton Keynes, the mental health program manager. And I think it's first fair to say that we're still work in progress when it comes to co-production. So we've still got a huge amount of things that we need to develop further, really making sure that we are truly making sure that we're listening, and we've got representation in all governance kind of structures around service users and carers. But hopefully today I'll be with Lee and Nikki will be sharing some of the work that we've got going on in relation to co-production from sort of a mental health perspective. And it's worth thinking that, of course, there's no health without mental health. So mental health is in everything. So it's great that we've got colleagues who from wider kind of systems or work streams, and how can we connect with ourselves as well around co-production. So next slide, Lee. So I'm just going to give you a quick, very brief overview, and then I'll hand over to Lee. So hopefully you're aware we're in the 4th year of the NHS long-term plan, and a commitment for mental health was the most ambitious transformation ever for mental health, and not without its challenges, as you're aware, with COVID-19 that we've all been focusing on, the cost of living crisis, the impact we know that mental health has had on people's, the COVID-19, etc. All these have had on people's impact on people's mental health and well-being, and the increase it's created in terms of demand on services. But having said that, when the NHS long-term plan was announced in sort of 2019 for mental health, we had an implementation plan that went alongside it. And one of its key local commitments, as you can see on this screen, was to make sure that we engage and co-produce with local communities, people with lived experience of mental ill health or mental health problems, and people who've used our mental health services, their families and carers. And the other key commitment it asked us to deliver was about really genuine partnership with the local public, the absolutely critical VCSE, voluntary care, social enterprise sector, and private sector organisations, and also to make sure that we've got a real focus on outcomes that address local health inequalities so that we can improve service delivery and transformation. So that was a key objective. Obviously, we're now coming to the 5th year of the first 5 years of the long-term plan for us in terms of transforming, improving, developing our mental health services. Next slide, Neil. So just to there's obviously lots of different models around co-production. But I personally really like this picture of the ladder, and essentially we're all for us, we're still trying to climb this ladder. So from the bottom of educating to coercion, which is essentially doing to, i.e. trying to fix people, our passive recipients of our services. We're trying, and I use the word trying because we're not there yet. We've still got a long way to go. We're trying to climb the ladder, i.e. the middle bits: engagement, consultation, informing, which is doing for, engaging, involvement. We're really trying to get to the top of the ladder, which is co-production, doing with, in an equal and reciprocal partnership. And that's, should be in all levels, all structures, in terms of our transformation, and really meeting the needs of our local populations across Bedford Borough, Central Beds, Luton and Milton Keynes. Obviously our transformation for mental health, all age as well, children, young people, adults and older adults. Next slide, Lee. So that's just gives you a kind of a picture of sort of a possible model that we've been sort of focusing on. So just before I hand over to Lee, so in mental health, there's a number of work streams that we are particularly focusing on, where we really want to be trying to embed co-production. And you'll hear from Lee about sort of the adult severe mental illness community care, and you'll hear from Nikki around children and young people's mental health. But just to give you an overview, as you can see, it's all age. We've done some great work around perinatal with the mobilisation of our perinatal mental health service and our maternal mental health services, but we still want to do more around co-production. Children, young people, Nikki will talk about that, but we've got hopefully you're aware, our mental health support teams in schools. We've improved our crisis services and our children, young people's eating disorder services, but again, we still want to do more co-production around there. Our talking therapy services called IACT, Improving Exercise Psychological Therapies for common mental health problems across BLMK. Again, how can we really embed co-production about making sure we're improving outcomes, experiences and access for people? Severe mental illness, Lee will talk about. And then crisis, obviously, again, the importance of our VCSE organisations like BLMK Mind, who provide our crisis cafes, and how our VCSE organisations can support us with co-production and meeting the needs of service users and carers. And then the other following bits are about improving inpatient care, older adults' mental health. There's a big focus, particularly at this moment in time in Bedford Borough, around suicide reduction, prevention and bereavement support, which is provided by Chums for Beds and Luton and BLMK Mind for Milton Keynes. And just some good news for us colleagues: harmful gambling, we're going to have some provision in our area, hopefully commencing April onwards. It's an East of England model, but as part of the model, we really need to make sure that we are co-producing it right from the beginning, in terms of, even though it's an East of England clinic, how's it going to meet the local needs of our residents living in Bedford, Central Beds, Luton and Milton Keynes. And then the other final bit is about having improve rough sleeping support, for which we've got dedicated funding in Luton and Milton Keynes, how we're making sure that we're utilising digital where appropriate, and looking at the data to really understand our local communities and really co-producing with all of our different communities in our communities. Next slide, Lee. And so the final bit is, alongside co-production, how are we really trying to address mental health inequalities? And for ourselves, there's a brilliant resource, in my humble opinion, called Advancing Mental Health Equality Strategy, and it's got a 4-step process about how we could advance addressing inequalities, but particularly for a mental health lens. And as you can see, I won't go through it, but you've got 4 boxes: identify, design, deliver, and evaluate. And a golden thread is about absolutely knowing our local population, making sure that we're co-producing services, improving quality, particularly with improving access, experience and outcomes, with our local communities, local population, the public, service users and carers, people who've used our service, people with lived experience. So hopefully that gives you a bit of context, and I'll hand over to Lee. Thanks.
Thanks, Michael. Hi, everyone. I'm Lee O'Neill. I'm the Business and Transformation Manager for Adult Mental Health for CNWL Milton Keynes, and I lead the Adult Community Mental Health Transformation Programme from the programme side here in Milton Keynes itself. So just kind of linking on really with what Michael has already been talking about, is around how throughout our transformation here in Milton Keynes, we really genuinely strive to put our service users and carers at the heart of everything that we're doing. So just on the left-hand side of my slides here was around actually how do we get to that? So there's 4 kind of key threads here that we work through for co-production here in Milton Keynes. So first of all was really at the start of this was looking at our culture. So are we ready within our culture, within our organisation and our transformation group? Are we ready for co-production? Do we genuinely know what it means, and do we genuinely have a passionate desire to commit to this throughout our programme? Also looking at things such as our structure, do we actually have a structure in place here for genuine co-production? Do we pay service users and carers for their time? What is in place to make sure that actually there aren't barriers there for people joining us on co-production activities? Then really just looking at things in practice as well. So co-production across our workforce, how do we ensure that actually really busy frontline teams have time to come away here to join in with co-production activities and be an equal part of that? Finally, as well, review. So how are things going? How are things working? And taking on board everybody's feedback and information around how they feel co-production is working in Milton Keynes, constantly reviewing that and making improvements. Just on the right-hand side, I thought I'd talk you through some of the things that we've been working through with co-production. So the first one there is around having joint workstream leads. So within Milton Keynes, our transformation structure has various different work streams here to deliver the transformation objectives. And how we set up those work streams is there's actually a lead in that work stream from CNWL. There's also a joint lead, and depending on work streams, that could be a voluntary sector organisation, it could be a patient and carer group, could be service users, and also as well our GP community. So we have some real joint leads on each of these work streams to make sure actually we don't just go down our kind of route of doing things. There's actually joint accountability there to say, we're really passionate here about ensuring that within our work streams, we're doing things together. The next kind of bulging out one here is our Mental Health Alliance. So here in Milton Keynes, we have a really active Mental Health Alliance, which we fund through the Transformation Programme to really reach out to all of those areas of the community. And that could be from your larger VCSE organisations right down to really small grassroots organisations to drive a culture of working together rather than competitiveness. And also as well supporting those really small grassroots organisations that we know offer so much here in Milton Keynes, but often maybe daunted around working with wider partners around things such as infrastructure and red tape, and how do we ensure that actually their voice is sat as an equal partner at the table. I also wanted to touch on a project around digital inequalities here in Milton Keynes. So throughout the programme here for transformation, something that came forward really regularly through co-production activities was around digital inequalities in Milton Keynes, particularly during COVID. So we were successful in a bid here whereby we were able to fund some work here as a co-production project where a social organisation came into Milton Keynes and spent time with service users, carers, voluntary organisations, to really paint what a new world looks like for digital inequality, specifically here in Milton Keynes, full of recommendations that actually all of us can pick up and take forward. You may have seen as well that we have our sensory gardens now open here at the Campbell Centre in our inpatient mental health unit. Again, this was a co-produced piece of work, working with service users and various organisations in Milton Keynes. We had a really lovely garden opening, and we heard back around people's feedback on co-production and how valuable they found it. Something that's quite new to us here, and it's something that actually I've brought from my previous life before the NHS, is around journey mapping. So journey mapping is relatively new in some cases, and I was working in a different industry in a big global company where we would custom a journey map to be able to really understand what people are experiencing, feeling, and how we can improve our services. So it's something that I was really passionate to bring to our transformation here in Milton Keynes. So what is journey mapping? So I've got a couple of quotes here. So patient journey mapping helps stakeholders to assess the patient experience from multiple perspectives. They visualize the internal and external factors affecting patient flow and the different paths patients must take in order to reach their goals. It says as well that the use of journey maps is a novel and innovative approach to understanding patient healthcare encounters. And I guess what journey mapping is it isn't a flow chart, it's not a process map. It's a real, genuine live document of how our service users, carers, and patients see, feel, think, and hear throughout their journey for services. And how this is normally compiled is we work with service users to actually understand their steps through the journey. For it could be a service, or it could be a specific thing that we're looking here to understand or improve. We then undertake what we call a high-level assessment of that journey area. So we talk through all the different experiences that service users have, and we ask them to rate them. So anything that's really outstanding, because there's some things as well that we do really, really well that we want to continue and make sure that we always do, right down to things that are actually turned our service users or our patients actually away from the service. So we can really understand as well both levels of the scale. From that as well, we put through some recommendations, so some real tangible things that we're able to do here to really improve the service user or patient experience from their perspective. So we've used this for the first time here in Milton Keynes, so I wanted to talk you through a little bit around the approach that we took here. So one of our dedicated focus areas for transformation is our eating disorders workstream. So this was selected as our transformation workstream for our first journey map. So when we did this kind of at the back end of last year, we reached out to recruit service users and carers through various channels. So you may have seen this advertised. It was on social media. We went through GPs, primary care networks. We also as well wrote to people that were in the service, and also as well we were advertising through voluntary sector, local libraries. So we're able to recruit some service users and carers for what is quite a small team here in Milton Keynes that see the ED service users here. And we held 2 workshops with them. So the first thing really was to understand with them how they would like this to be set up. So rather than us doing to the service users, telling them they need to come into a hospital setting to talk about their experiences, we worked with them and we set up a central, really neutral location in Milton Keynes. And throughout those sessions, we walked through service users' journeys and experiences around 4 key areas. And these were defined by service users. And you can see these at the bottom here. So we asked internally for our own colleagues to say, what's the start and the end if you had to really kind of group up some of the experiences here of an eating disorder? And then we actually then sense checked that with what service users told us. We were pretty much accurate. There's a little bit of change there, but they told us if they were going to talk through the 4 main stages of living with an eating disorder, it would be, I feel something is wrong, or I'm told by others that something is wrong. I'm accessing local support. I'm accessing a specialist service, and I'm living with or recovering from having an eating disorder. So we went through, we discussed, we rated those experiences, and they came up with recommendations to be able to enhance their experience and close some real obvious gaps that probably looking at a process map or not standing in their shoes that we wouldn't have seen. In addition to that, to create a really in-depth type of process, an in-depth kind of customer journey map, patient journey map, we actually surveyed primary care teams, CNWL staff, ICB teams also received a survey, VCSE organisations and patient engagement groups, and we were able to build their experiences of working with adults here in Milton Keynes who have an eating disorder into that map to give some real in-depth information. So really, what did we learn here? So it was a lot of information came through, but I can give you some really key early themes that have actually just come out because we've only literally just finished putting together the first draft. One of the main threads throughout from service users was around communication. So the first one was around the website and CNWL's own website, around accessibility, trying to search for information and trying to understand where to go. So service users were able to give us some really good insight into the pitfalls here, where things are going wrong, to the point that actually we've now managed to get somebody fixed term who's on secondment, who is currently working through our website on those recommendations to be able to do some real-time change for service users. Letters was another one that we looked at when we talk about what people see, think, and hear. In the letters, the area that they're going for kind of outpatient treatment, the setup of that is actually you don't see a reception desk. So when you go into there, you sit into the area and the clinician will come and call you. So although they may have had an initial call with their clinician who's reminded them of that information, actually by the time the appointment comes, this was a real high level of stress for people because they came in, they couldn't find the reception team, as you would expect when you go into maybe an appointment, thought they might not be seen, they didn't know how to get hold of someone. So actually, we're going to now add in into our letters, which most people bring to their appointments, some really in-depth and key information of where they need to go and just that reassurance that somebody will come out to get them. Referral processes came up between different professionals, bit unsure, a bit unclear. So referrals were bounced into different areas. Actually, there's some really clear work we could put in here to show the different referral pathways. Digital was also as well another area that came up. And this is around offering digital, but also as well sometimes the consequences of digital. One of our service users told us that actually by having digital appointments, they weren't able to separate that appointment as if they would if it was in a face-to-face setting. So I've got a bit of a quote here where one of the service users says that actually I can't go into that room anymore at home where I had my treatment. I also can't sit on that sofa. I now call this the bad news room. Just on the right side is trusted information. And one of the key things that came out from service users was around there's a lot of information out there. I want to see trusted information, and I want to see trusted information with an NHS stamp on. That's the only information that I will take as information that I feel that is trusted. This included having literature at GP surgeries, recognised blogs, especially when recovery and living with a condition, and also NHS accredited resources that would be available maybe on our own websites or in other areas, including things such as libraries and local community assets. The bottom left there talks around local support. So we've identified a gap here of local discharge support, which we're working through within our transformation programme. But also as well, our GP and primary care teams told us that actually they needed some more support here when it comes to supporting people living with an eating disorder at that local level. Service development was around expanding our support offer, so offering different types of eating disorder interventions. Workforce challenges came up, but not only from professional and our internal teams, but also as well from service users who really shared a sense of guilt at the moment of coming forward and using NHS services when in the media it's constantly put out around how stretched resources are. And sometimes people wait until they're really unwell to then step forwards to ask for support. Things such as clinical environment as well, things we maybe not have realised. One of our clinic rooms is next to a kitchen. When people are coming in for eating disorder interventions, they can hear microwaves. They may be able to smell different foods and things that are going on. These are things that we can fix. And also something that came up constantly as well is support for males throughout the eating disorder journey, and how actually whether it comes to information and support, that there was a lack of information out there. So very early key themes here, but some of these things are not requiring massive amounts of investment and massive amounts of time to change, but some things that were really important to service users and patients, but actually sometimes can often get overlooked. So once this report is complete, where will it go? So we'll share this as transparency with all our partners at the Mental Health Transformation Board. And also as well feed into our eating disorders transformation work stream. As I said, that's made up with a variety of different people as our co-production approach to be able to take some really tangible things forward here to be able to change. Also as well, finally, we will share it as well with our primary care teams and our CNWL forums to make sure as well that we've also closed the loop with our own internal staff and also with professionals. So yeah, that's the end of the presentation. You're welcome to ask any questions, or my contact details will be shared if this is an approach that you might think about taking or you wanted some further information on. You're very welcome to reach out to me.
Thank you very much, Tom and Michael. That was really interesting. Thank you very much. We've got one hand up in the participants list. I think that's Tom May. Have you got a question?
Yeah, it was going back to Michael's slides. You listed a range of work streams that you're involved in, you know, from the gambling, etc. That big list. I know that we've done work in the past around long-term conditions. Is there any? I didn't see it on the list, and is that because we haven't done any work on co-production specifically around long-term conditions, or is there any ambition to do some work around co-production and long-term conditions in the future around mental health?
Thanks, Tom. Sorry, I haven't got my cameras. Apologies. So, absolutely. So, Tom, so what we're trying to do here, colleagues, is no two doors. We're not trying to have a door for mental health and a door for physical health. You know, we're trying to have just one, you know, one door. And as you rightly say, so talking therapies and long-term conditions, diabetes, you know, cardiovascular, etc., that falls under on the slide there, Tom, on the common mental illnesses, the IAP slide. So, but to answer your question, absolutely, Tom, you know, which is why it's wonderful we've got a range of colleagues here. We absolutely want to, you know, the whole idea of integrated talking therapies and long-term conditions is about thinking about co-location, integrated pathways, really thinking about outcomes, people not being bounced between different services, you know, not one, as I said, one door for mental health, one door for physical health. So Tom, I think in colleagues, there's an absolute opportunity that we really want to be co-producing our integrated IAPs and long-term conditions services. And our IAP services, we've got 3 providers, Total Wellbeing for Luton, ELF for Bedfordshire, and CNWL for Milton Keynes. We'd be really, really keen on how we can really make sure that as part of that development, we're absolutely got co-production as a central theme. And Tom, I know you've always been really supportive. So if you're interested, colleagues, please feel free to email me and I can connect you with the IAP lead so how we can take this forward. But absolutely, Tom, and I saw a national focus around long-term conditions as well. So this is going to be even more important for us. So Tom, yeah, it's absolutely critical. It falls under common mental illnesses.
I think maybe when we have a next meeting, I don't even know if we've got one in the diary at the moment. Maybe if we have a specific agenda item around co-production in that long-term conditions group, because we've mildly touched it, and I don't know how much has been done, but I think there's definitely mileage in the partners having a discussion on how we might make that a bit more mainstream in terms of that work stream.
Definitely agreed, Tom. I'll for our next meeting, I'll add it to the agenda. So it's an absolute area that we should be focusing on, Tom, but it needs partnership working, as you say, with leads for the long-term condition strands as well.
No, sounds brilliant. Cheers, Michael.
Thank you very much for that question, Tom. I think it's a really interesting point, and I wonder if having standing agendas or standing items on work streams about co-production and understanding whether or not they're working in other areas would be helpful to develop that theme and thinking about if we've, you know, if we've got a work stream, how are we co-producing this? How are we involving? Are we fulfilling our duty to involve? I think it's really important. And we've got another question from Daniel, which is Ray. Did I say that correctly, Daniel?
That's fine by me, Rachel. So just a quick question. Is there any co-production work being completed with homeless people?
Yeah, so that's a good point. So Luton, we were very lucky. We got national funding, 300,000 for Luton as identified areas high need. So that's been a real partnership approach, Daniel, with organisations such as NOAA, the local council, etc. And they've really been focusing about, as part of that development, it's several years old now, actually. I think we're coming into we'll be coming into the third year of since it started. And there's been a big focus about really working, obviously the focus about improving mental health care for rough sleepers in Luton. And there's been a real focus right from the beginning about co-producing it with with rough sleepers, the design, lived experience input, and also thinking as well about peer support workers as well, as part of the model. And we've also, Daniel, got funding for Milton Keynes, 150,000 actually, where we've also been mobilising, trying to increased mental health support for our sleepers. We do have some provision in Bedford and Central Beds, but we don't have national NHS funding. So yeah, Daniel, I can connect you with colleagues from Luton, and they've, right, because I've been involved right from the beginning, they've really tried to, design or develop their services so it really meets the needs of rough sleepers, touching on some of the things that Lee have said about thinking about location, again joining, as Tom's mentioned, the physical health kind of care alongside the mental health care, thinking about how do we reach our rough sleepers, meet their needs, making services accessible, thinking obviously person-centered about their whole needs. So yeah, Daniel, that's been a key theme, and that's where the VCSE organisations can really, it's great we've got Michelle, etc., on the call. They can really help us, organisations like NOAA, etc., in Luton, who really know our local community. So yeah, I can connect you, Daniel, but I'm speaking on their behalf. I think they've done that is an area with obviously work in progress. We've got lots of areas, as Tom mentioned, where we need to do more, but I think that is an area where they have done quite a lot of work in terms of co-designing, co-developing, co-producing the service with rough sleepers, particularly in Luton.
Perfect.
Thank you
you,
very
Michael.
much, Michael. That's really helpful. I think we're going to, so that we stay on track, we're going to need to move on to our next presenter. So thank you very much, Michael and Lee, and thank you for the questions. They've been really helpful. Nikki Scott, welcome.
Thanks very much. Thank you. And lovely to see everyone here today. So let me just get my slides up. And just to introduce myself, so my name is Nikki Scott. I'm the participation lead for CAMS in Bedfordshire and Luton, which is the East London Foundation Trust. And I have been in post for nearly 9 years. So co-production is something that isn't new to us at CAMS. We've worked historically with young people, families, parents and carers on projects. But I wanted to talk to you today about the development of Evergreen, which some of you may have heard of. So Evergreen is the new 8-bed Tier 4 CAMS inpatient ward, which is due to open in February. The date keeps getting pushed back slightly, but I've been told February the 27th. And I wanted to talk to you specifically around how we've worked all the way through with young people and parents and carers to co-produce every aspect of the development of Evergreen. So okay, so you may or may not know that we have never had inpatient beds in BLMK for young people. So if a young person does require inpatient care, they literally could end up anywhere in the country, which has obviously been a real issue and has a massive implication on families. So going back to June 2019 is when we first started meeting with young people. We set up some workshops to talk to young people who had experienced inpatient care, to talk to their families about what that had been like and how it had impacted on their families. And the key things that we learned from them was that there had been a real lack of communication around admission, treatment, discharge. Obviously, these young people were in beds which weren't our beds, so it was really difficult to know exactly what was going on. They could be placed literally anywhere in the country, so that would obviously have a huge impact on everyone. There was a lack of control around the care that was taking place because they were so far away from home and there wasn't consistency in family meetings. They often were in hospital for really prolonged periods of time. And when it came to the discharge, because we weren't involved in the care of young people on the wards, it was really difficult to sort of join up all of that together. So following on, that feedback that we took in June 2019 actually formed part of the bid for the funding to develop a local space in Beds, Luton and Milton Keynes for young people. So in July 2021, we set up the first of our workshops, which were held monthly. They were hosted by professionals from CAMS in Beds and Luton, but also in Milton Keynes. And we held workshops once a month with young people, parents and carers. We promoted these through our local parent carer forums. We wanted to ensure that we had a really diverse representation of attendance from people across Beds, Luton and Milton Keynes. And at each event, we gave them updates on progress and gathered feedbacks about their experiences and what was really important to them when thinking about the development of Evergreen. This was a survey that we put out. So one of the really important things right from the start was not just to talk about the local inpatient ward, but to actually choose a name. And we wanted to give ownership to our young people to actually think about an appropriate name for the ward. So we put surveys out through all of our clinics. We had posters with QR codes so people could submit their ideas for names for the ward. We promoted it through social media. And I wanted to share with you now a video that we made, part of a video. So this was launched in September 2021 and talked about why the inpatient ward was so important. But the key thing that I wanted to share with you here is the experience of one young person from Bedfordshire of her inpatient stay. So.
There are currently no inpatient units for our young people across Bedfordshire, Luton or Milton Keynes. A temporary facility is being planned, but our proposals will provide a long-term site for young people across Bedfordshire, Luton and Milton Keynes to be supported much closer to home.
I was 13 when I went into inpatient care in Essex, Rochford, and the impact it had on my family was dreadful, especially my mum. She was doing day and night shifts trying to get money to be able to come and see me, but then not having enough money for food, so having to go to food banks. And having a unit in Bedford would have been beneficial for not just me, but the whole family, because I would have been able to see my brothers more often, whereas when I was in Essex, I didn't see them at all. And also having friends that I go to school with, having them to come and see me would have just made me feel not as isolated. And I feel like if I was able to have them around me, I could have probably got out of hospital a lot quicker, because having the impact of my mum struggling and having no one around me made me stay in hospital longer.
And I think you'll all agree that's a really powerful story. And quite often when we think about where a young person's going to be, I think there's often an attitude that families should be grateful that a bed is available without thinking about how much it affects the whole family. Susie talked there about, the expense on the family, the journeys to be able to go and see a young person in hospital, the impact on Susie of not having any contact with her siblings for a prolonged period of time. So it's a really powerful message, I think. So I'm going to give you a bit of a timeline now about the length of this project. So we started the workshops in, as I say, June of 2021. November 2021 was the first time that we met with the architects who had been employed to work with us on the development of the unit. So at this point, we had announced where the ward was going to be. We had secured an existing space at the Luton and Dunstable Hospital, which we were going to convert to an 8-bed inpatient ward, and that's at Colmwood Court in Luton, for those of you who know the Luton and Dunstable Hospital. So the architects joined the workshops with young people. They were involved in talking about, you know, everything from the furniture that would be in place, really thinking about the sensory needs of young people. A lot of the young people who have been part of this are neurodiverse, so it was really important that we thought about the feedback that they'd given us, and quite often that they said that actually there was so much focus on the care that they received for their mental health needs that often their sensory needs weren't being met while they were inpatients in whatever ward they had ended up in. So it was really important that we took their feedback on board. We also looked at the layout of the dining room with the consideration for young people with eating disorders, the importance of having private eating spaces. Because Evergreen is quite a small space, it's obviously not purpose built. We were converting an existing space. We had to have multi-purpose rooms. So we worked with service users to think about how we could double up those spaces, what would be most effective. We needed to ensure that there was space for family meetings and visits. We've got a very small outdoor space, but we wanted that to work really well for us. So we worked with young people to think about what that might look like. And really importantly, I think the young people spoke to us about the fact that they wanted the space to feel really comfortable and not look too clinical. So they were involved in everything from choosing the wallpaper to thinking about how the rooms look, the furniture. And then in December 2021, following lots of feedback from the surveys, our young people chose the name Evergreen. So they'd chosen a nature theme, and Evergreen was chosen as the name for the ward. But then they went even further and said, well, actually, we'd like each room to have a nature theme as well. So in February 2022, our young people and our families met with the Evergreen education team. So they were involved in helping the education staff think about what the equipment they might need for the classroom, thinking about what the school day might look like, and the importance of having access to exams and coursework while they were inpatients. I think it's really important that, you know, we're not just focusing on their journey of recovery, but we're trying to ensure that, you know, their lives aren't implicated too much with regards to, you know, breaking up their education. So really thinking about the fact that everyone's going to have different learning styles, different needs for engagement. So they were heavily involved in all of the equipment and the planning of what a school day might look like on an inpatient ward. That's a picture that we took yesterday, actually, of the education room and the staff that have been employed. There's some images of the classroom. So May 2022, this is one of our young people on our first site visit to Evergreen. And this is a picture of the staff. So the Evergreen staff, we're 90% recruited to now. Young people have sat on every single interview panel. So from employing the psychiatrist down to employing the receptionist, our young people have been involved in choosing appropriate staff to work with young people at Evergreen. From September to October, our focus was on working to produce the clinical guidelines, the service philosophy. Our young people helped us to develop the welcome pack that they would receive. and the activities calendar. So what would be happening on the ward on a daily basis, what activities would be available to our young people. And here's some pictures of the Evergreen ward. So you can see each bedroom has a themed name. That's Maddie on a site visit in October 2022. And then another one of our examples of co-production was young people actually delivering training to the staff at Evergreen. So in October, we had Maddie delivering training to around autism to our Evergreen staff. And then we had Jay and Sassy from our team delivering gender identity training to our staff. We were asked to make a presentation to the NHS East of England in October 2022. So we took 3 of our young people along to that event, and they spoke about why they had wanted to be involved in the development of Evergreen and what it meant to them. So I've got an audio recording I'm going to play you here, which is Maddie talking about her journey. Oh, just one second.
Hi, my name is Maddie. I'm 18 years old and I am an ex-CAMS service user. My inpatient journey began with an admission to a hospital in Northampton on the 20th of November 2019, 31 miles and a 51-minute drive from my home. I was 15 and dealing with severe mental health difficulties. I never even knew adolescent inpatient units existed, never mind being admitted to one. My mum took me and I was terrified. The whole drive I was panicking about where I was going and what would happen. I was lucky that my parents had cars and could visit me twice a week, and could afford to miss days at work and stay in hotels overnight so that they could see me 2 days in a row. Other patients weren't so lucky and had family hours away. I was discharged on the 4th of February 2020 after almost 11 weeks. Unfortunately, my inpatient journey began again on the 4th of July 2020. But this time, the unit was even further, 64 miles, an hour and 36 minutes away from home. I didn't see any family or even get to leave the building for 5 weeks. I was stuck between 4 walls 24/7. I witnessed some truly horrible things. I was lucky that this unit had iPads that could be used to FaceTime family. This made things a lot easier. I was lucky to receive outstanding treatment and finally got my autism diagnosis there at age 16. That's helped me to understand who I am. I was discharged on the 10th of September 2020 after 10 weeks. Things didn't improve for me, and I went into General Hospital for 2 weeks on the 27th of November to the 10th of December. They decided they were going to send me to Manchester, 3 hours and 26 minutes away. Our response was a flat out no. How would sending me over 3 hours away help? They then found a bed in Birmingham, still 71 miles, an hour and 42 minutes away. But we had no choice, and this was the closest bed they could offer. They made it especially clear that they wanted me out of the general bed that I was taking up. This last inpatient admission left me with PTSD that formed a few months after and still affects me to this day. If I was able to be sent to a unit that's closer and one that had actual resources to help me keep up regular contact with family, I don't believe this would have developed, and I know that I wouldn't have had to face a lot of the difficulties that I did. This is why closer units are so vitally important. They are game changers in the care and treatment of service users and make it possible for service users, community team, to meet the staff at the unit, and means the team can be present in important meetings regarding that person's care. It also means that patients are able to get back into the community quicker, as they're able to have more regular contact with family and friends. It has been amazing to be involved in the development of Evergreen. Being involved has helped me significantly with my own recovery. Being able to speak about my good and bad experiences constructively to a team of people who are there because they genuinely want to help and make a positive change has been amazing. Having the opportunity to speak to people who take my opinions and my experiences forward and are constantly striving to make changes that will help so many young people in the future has been incredible. Just knowing that young people in the future won't have to go through the majority of negative experiences I did gives me a massive sigh of relief. Being able to share my negative experiences to create a much more positive experience for other young people in the future has been fantastic. Part of my involvement in the development of Evergreen is bringing the perspective of a young person with autism and voicing what it's like being a unit and the extra challenges I faced while being inpatient.
There's so many powerful messages in that audio, and I thought it was really important to share that with you, not just because it really highlights why this was so important. It was so important to have local beds in Milton Keynes, because Maddie's just one of so many young people that have been sent hundreds of miles away from home, and you know, 3 inpatient stays, and talking about, you know, how that's impacted her life now. But what I really wanted to highlight from that was not just the benefits to the service of having young people involved, but the benefits to those young people. Maddie talks about how this has been really key part of her recovery. And I think it's really important to reflect on that and to think, you know, this is such a two-way process. And that's just one young person's feedback. So just to really finish on why co-production is so important. Service users feel valued and listened to. Maddie talked about that, you know, people actually listening to her and it having an impact on a project. It's empowering, it helps with their recovery. And for us, it allows us to strive to provide the best care that represents what young people want and what they need. And finally, engaging young people to have an active say and improving services and holding them to account when things don't go right. So that's the end of my presentation. I hope you found that helpful. And yeah, I don't know if anyone has got any questions at all.
That was wonderful, Nikki. Thank you so much for that presentation, and just what an enlightening piece of work to involve young people at every single stage of the process and right through to co-production and delivery of training, and just shows all the benefits really of co-production. What a wonderful example. Does anyone have any questions for Nikki? I've got no hands up at the moment. You've stunned them all into silence, Nikki.
And I think I just really wanted to highlight, this is just one project that we've done at CAMS in Bedfordshire and Luton. So, you know, it's been a really long project. I was there again yesterday. So our next task with Evergreen is that, so yesterday I was there with Maddie and with a filmmaker, and we're going to be filming a video tour of the unit, because we think it's really important that families and young people know what to expect should they need an admission to the ward. So that's our next project. But yeah, I can see that there might be a couple of hands up
wonderful.
now.
There are, yes, thank you. Michelle, your hand was up first. Michelle Evans-Richies.
Thanks. I just want to say how inspired I have been by that. And you picked up on what I was going to say was about how powerful it was for that young lady to, as part of her recovery, it's almost like helping others has helped her, and I thought that was really profound. So I work with the governance team, and it'd be really good to have this as a case study for the ICB board, about how we work with service users to design our services, and particularly young people. It's really important that they have their say and they're listened to, because we don't know the answers, and that's true for everybody, but particularly young people. I think it's really important, and when they can see that we're taking their comments seriously, it breeds that sort of trust and empowerment, doesn't it? So I just think it's wonderful, and the more we can do this, and you're right, it does take a lot of time, and actually planning that into any time schedule is really important. But I just want to say how moved I was by it. Thank you.
Thank you, Michelle.
Thank you. We've got time for one very quick question. Michael, you've got your hand up.
Yeah, Rachel, it was just more of a point. So, I mean, obviously we focused on mental health, colleagues, and I'm really grateful for Nikki and Lee for sharing it. But it is worth noting we are still work in progress, aren't we? We've shared some initiatives, but what I want to say is a more general point. There's some brilliant national guidance to support particularly commissioners around co-production. And what it says is co-production is messy. It's messy, it's difficult, it takes time, it's not easy, we make mistakes, we learn, you know, some of what people tell us obviously, you know, is challenges us, etc., etc. And so there's some national guidance that says, you know, co-production is messy, and so we've still got a long way to go. And as people say, it, you know, it takes time, you know, it listens, it challenges us, and it's not easy. So just to give you that kind of feedback that it isn't easy, is it?
Not at all. Nikki, final words? You've got your hand
Yeah,
up?
just to really reiterate that, you know, you do really have to invest time and money. I've been in post for 8 years. I worked on my own for probably the first 5 years. I now have 6 people in my team. Elft have really invested in co-production. Our young people are rewarded for their time, their enthusiasm. They are paid in exactly the same way as we would pay our adult service users for their involvement. And I think that that's really key. It's really important. So, you know, it's ensuring that actually you are encouraging as many people, as diverse a range of people as you can in co-production. And I think, you know, that's what's taken a lot of time, really promoting it and going to where people are.
Thank you, Nikki. Really, really powerful. Thank you. We're going to finish up for today. We literally ran to the nail on our timing. Our next co-production webinar is in March 15, and we should be talking with Taylor Tukey from the YMCA about co-production and with young people, and we'll have hopefully a presentation from the Cancer Patient Forum as well. If you have signed up for our training, thank you very much. And we've had 5 or 6 people already sign up whilst we've been on the session, so keep going. Please do click on the links, and we'll leave the link on the chat as well for you to click on there and scan to get your training underway. They'll be running through till May, and we're looking at expanding the programme as well. So lots to get involved with co-production if you want more information and more support. We'll send out the slides to everyone who has attended, so please do shout, and hopefully we will be uploading this onto our intranet for people to look back and have another listen again. Thank you very much for your time, everybody, and lovely to see you all, and I hope to see you in March.
Thank you.